So we're up to our next presenter. We have Hank Hrdlicka. Look at that, Hank, I got it right. He is a PhD and the Director of Research at Gaylord Specialty Care. He's going to discuss the remarkable results from the impact of virtual sitting on decreasing falls in the LTAC. Now, this is so important. It kind of mirrors into Angel's presentation. So don't step away. If you're not an LTAC, that's okay. Stay here so you can help build out those conversations and those collaborations with your LTACs and SNFs. So without further ado, I'm going to hand it over to Hank.
Hi, Dana. Thank you so much for having me today. Again, my name is Dr. Hank Hrdlicka, or Henry Hrdlicka. I'm the Director of Research at Gaylord Specialty Healthcare's Milne Institute for Healthcare Innovation. And it's my pleasure today to be talking to you again about our study where we assess the impact of continuous visual monitoring, telesitting, on inpatient falls and one-to-one sitter use in the LTAC setting. So just to kind of start some things off, just some base disclosures and disclaimers. Just want to state up front that I have no financial disclosures or personal conflicts of interest to disclose today in relation to this presentation. And just as a disclaimer, the research data presented here today is not yet published and is the property of Gaylord, but we're very close to getting it out the door for publication. So that's very exciting as well. So to begin, I'd really like to set the stage and the setting for the talk that I'm giving to you today. This all occurred at Gaylord Specialty Healthcare, which is a rehabilitation-focused nonprofit healthcare system in Connecticut. It's anchored by Gaylord Hospital, but Gaylord Specialty Healthcare also provides 5 outpatient rehab clinics throughout the state. And Gaylord Hospital itself is a 137-bed long-term acute care hospital located in Wallingford, and we're comprised of 6 inpatient nursing units, including 2 step-down or progressive care units, 2 medically complex units primarily focused on stroke or telemetry, and then 2 rehabilitation units. Our primary populations there tend to be SCI, TBI, stroke, and ortho patients. And as I very much doubt that I have to say to this crowd, but inpatient falls are universal safety concerns. And at Gaylord, as I'm sure most of us also do, we follow the Joint Commission's definition of falls, where a fall is any unintentional change in position coming to rest on the ground floor or onto the next lower surface. And the key point of that is the unintentional change. So it's any time, and it can be from a bed to a chair, bed to the floor, or wheelchair to bed, or wheelchair to bed, as long as it's unintentional into the next lowest surface. And that's also guided or unguided falls as well. And we find that this is especially a concern in the LTAC setting, where individual risk is increased by our longer lengths of stay, and with patient mobility and independence frequently being encouraged as soon as the patient is able. And as I'm sure many of you can relate, we've spent several years addressing falls at Gaylord Hospital and Gaylord Specialty Healthcare. Kind of taking you through the brief history of what we've tried in the past. Starting in 2013, about 10 years ago, we took the initiative to note that falls were becoming a major concern. This led to the creation of a multidisciplinary falls committee. Some of the early changes that the falls committee implemented included the creation of a post-fall huddle, purposeful hourly rounding, and adoption of the Johns Hopkins Hospital Fall Risk Assessment Tool. Even with these strategies in place, falls continue to be a concern. And the next big milestone in our fight against inpatient falls came in 2018, 2019, where we started an initiative to reevaluate our fall prevention program. This reevaluation led to the expansion of our fall committee, revisions to the post-fall huddle forms, and modified EMR documentation. And to note, the improved and modified EMR documentation was important, as it allowed us to better track the events leading up to and after the fall, and just to be a little bit more nuanced in what we were recording. The fall prevention campaign also included staff engagement, where staff were allowed to select the fall risk symbols and signage. And there was creation of educational fall prevention posters that were placed around the hospital. And these show patient tools and interventions so that they too can become involved in their own fall prevention education. And throughout this time, we had been using one-to-one sitters. They had been implemented since the beginning, as I know we've been talking about a lot today. However, and as again, I'm sure everyone can relate, one-to-one sitters can reduce the number of inpatient falls and other adverse events. However, their use at times can be less than ideal. They're difficult to schedule and often result in staff being taken off the floor and away from other patients, or asking staff to stay late or do stay for overtime. Often the demand outpaces staff availability, and because the uncertainty and the occasions where staff are having to be pulled off there to complete their work, this does accrue a massive financial burden on any institution. And unfortunately, over the last 3 years, these factors have been further exacerbated due to ongoing national staffing shortages, as well as the COVID-19 pandemic. And this led us to the conclusion that an alternative needed to be found. So starting in September 2020, our Chief Nursing Officer, Lisa Kalfas, who unfortunately couldn't be here today, began investigating remote telemonitoring systems to aid in fall prevention. In her initial literature review and then what the research department also then supported, we found that there was little to no research on the use of telemonitoring to reduce patient falls in the LTAC setting. And together we determined this was a great opportunity for the nursing team to take the lead and to investigate this gap in knowledge. So then in January 26th, we had engaged with Abasher and we launched our telesitting program. It launched then again January 26th, 2021. And I'll talk a little bit more about it, but coming together, nursing and Gaylord's Mills Institute for Healthcare Innovation worked together then to develop an observational study. But before getting into the details, specifics of the study, I just kind of want to highlight the equipment that we're using. We initially launched with 10 mobile cameras. These are the Guardian 2. And then eventually we added in 2 additional cameras around October 2021. As we all know, these cameras are all equipped with 2-way audio, 1-way video. And as Dana highlighted there, in between sessions, these do not record any video. So it's all live feed, no recording whatsoever. And so with our current setup, after having added in those 2 additional cameras, a single telesitter was then able to remotely monitor and interact with up to 12 patients at a time. And our criteria for telesitter assignments were the same or are the same as our one-to-one sitters, including patient alertness, impulsiveness, limited awareness of limitations, impaired bladder or bowel management, cognitive impairments, and fall risk score. Again, we use the Johns Hopkins fall risk assessment. And so the study that we designed we started off by establishing what goals we wanted to highlight or what hypotheses we wanted to highlight. And our goal was set to assess the impact of telesitting on inpatient and one-to-one sitter usage. And we also decided very early on that we wanted whatever study design we created to have no bearing or effect on implementation of the telesitting program itself. So that way it can run independent of the study. This also helped to make the study a little bit more agile and nimble as far as then collecting data. So addressing these 2 points, we decided upon a prospective observational study and settled on a 20-month prospective period. And then we also included retrospective or historical components for comparison of the primary outcomes. And so the reason we selected 20 months was going into this, we had been told by our representatives at Abasher that the initial 6 months were going to be a learning period. So with that, we wanted to then make sure that we could also capture that initial 6-month learning period, but then also then get a clean stretch of data as well. So that led us to rounding it out to 20 months. And so for the perspective timeframe, we collected data from February 1st, 2021 through September 30th, 2022. Retrospective data were then collected from June 1st, 2019 through January 31st, 2021. And the primary study outcomes that we followed included adverse events avoided. So as many of us will know, anytime a telesitter redirects or prevents an unsafe behavior that could lead to an adverse event, it's recorded as an adverse event avoided. And this data is recorded and then accessed then later on through the Abasher's telesitting portal. We also tracked inpatient falls and one-to-one sitter hours. And so the inpatient falls and one-to-one sitter hours, this is where we use that retrospective or historical data to compare it against. And we made sure that it was an equal length period of time as well. So then jumping into our patient data, we see that in the 20-month period between February 2021 and September 2022, there were 448 telesitting admissions. So anytime someone was put onto the telesitting protocol, of these 64% were male, about 36 were female, and the average age was 64 years of age. and the average monitoring time was about 13 days. Interestingly, positively, the top 4 most common reasons for telesitter discontinuation, the top reason was behaviors improved. That means that the patients no longer required a telesitter or a one-to-one sitter. The second was that the patient discharged from Gaylord. Third was the unit was reassigned to a higher need patient. So with the algorithm that we're working within, there are instances where we can then reassign patients to someone or reassign the unit to a patient who may need it more than another. And then our last top 4 most common reason was emergent transfers to acute care hospital. So it's oftentimes situations outside of our control. So with the patients that were admitted, the 448 that I mentioned previously, of these, as you can see highlighted by the light green box, over 75% of them, of the patients were admitted to the telesitting program due to, at least in part, a potential fall risk. So what that means is that patients can be assigned a telesitter for multiple reasons. Falls may just be one of several. So we can see, looking at all the ones that had been assigned a telesitter for a concern of risk or fall risk, we can see that there are 77.9% or 349 out of the 448. And so some of them, after those categories with falls, we see medical device interference, COVID precautions, and elopement risk for the vast majority of the others. So looking at our first primary outcome, potential adverse events avoided, again, this is anytime a telesitter stops or prevents an unsafe behavior that could lead to an adverse event, it's recorded as an adverse event avoided. So in those 20 months, we recorded over 7,000 potential adverse events avoided, that adverse events that were avoided or redirected by a telesitter. And to direct your attention to the table in the middle of the screen, across the top, we have the category of the possible adverse event avoided, a count and percentage. And then in the third column, we have the count normalized per 1,000 patient telesitting days. This is just to get a sense of, for every 1,000, taking the total time that our patients were on telesitters, dividing it by 1,000, we're then able to normalize the data just to get a bit of a cleaner look. This kind of accounts for differences in census and all that. But amazingly, what I really should be directing your attention to is the falls. Over 90% of these 7,049 potential adverse events, over 90% were falls, which is incredible. These, and after that, we have device dislodgements, elopements, others. And then the one that surprised us the most, actually, going into this, was abusive behaviors. And what these were not abusive behaviors from patient to nurse, but it was abusive behaviors from visitors to patients, which we didn't expect to see. And I'm sure others may have observed that as well, but it was just something that we weren't expecting. And we're just grateful to have our telesitters in the room to be able to see that and redirect those instances. And the thing that we say internally, and what I would like to share with you all as well, is that we can never know if these potential adverse events would have occurred in the absence of the telesitter program. It's impossible to know. However, we can be certain that these potential adverse events in high-risk behaviors never have the opportunity to escalate. And I think that's the most important part. So moving on from there, let's talk about inpatient falls. So to kind of orient you to the table that you're seeing right now, we have in the first column the falls, both the sum total falls per month and then falls per 1,000 patient days. And then we have it broken down by the reference period. So this is the historical 20-month period, the telesitting period, and then the difference in some statistical values. And so what we can take away from this is that between the reference period and telesitting period, we saw a reduction or a difference of 86 falls. This equates to about a 25% reduction in falls during the telesitting period. And this showed to be a significant, even when we normalized it for falls per month or falls per 1,000 patient days, we found this to be a significant change. And then looking at the breakdown of the falls that occurred during the telesitting period as well, we were able to kind of look at the nuance of were telesitters present at the time of fall, were they not? And we can see that of the 257 falls, only 27 only 27 of the 257 falls occurred with a telesitter present at the time. And just to note, there was, of the 27, only 4 patients accounted for 14 falls. And these were just very high risk, very agitated patients that we were doing anything and everything we could for these patients. But again, telesitters were present. And then for the 230 instances where the telesitter were not present, 157 of these, the telesitter was never assigned before or after the fall. The telesitter, for 43 of them, telesitters were activated after the fall. So the fall prompted the activation of the telesitter protocol. There were 20 instances where the fall occurred outside of the patient's room, even though, so they were assigned a telesitter, but they were at therapy. So they were outside of the room where the telesitter couldn't go, or the equipment couldn't follow them. And then for 10 of them, the telesitter actually had been discontinued prior to the fall. So there were 10 instances where a patient had been on a telesitter, behaviors had improved, and so they had been discharged from the protocol, and then they proceeded to have a fall. So that tells us that there is some room for improvement in our algorithm and trying to get better nuance how a reassignment, which we've been looking at as well. And so again, I want to highlight that only 10% occurred with a telesitter present, but there's also been many variables over the last 2.5, 3 years that have influenced these. And I'd like to share with you now what's called, for those who aren't familiar, this is a control chart. And what we're showing here is on the y-axis, we have falls per month. And then along the x-axis, we have the months themselves. So with these, you can see that they're only showing every other month. That's just for spacing. But we have in the dark blue hashed line, this is the average falls for that respective period. So on the left half of the screen or left half of the chart is the reference period, and the right half then is our telesitting period. We can see that at various times, either COVID prep, COVID spikes, visitor restrictions, all may have had influences that may cause spikes in falls per month above the upper limit. So that's the lime green or light green color. And this is showing the 95% interval, both that and the dark green below. So we can see that there's a very obvious downward trend during the telesitter period that reflects the 25% decrease that I had mentioned previously. And then we get into our last primary outcome, which was one-to-one sitter utilization. So again, this is a very similar chart to what you're seeing, table that you're seeing here to the right. We can see that for the reference period in total, over the 20 months, we've had 28,560 total one-to-one sitter hours. This compared to telesitting, which only had 2,800 hours total. And I'll show you a visualization of what this looked like here in a moment. But just to kind of take in the fact that this difference was, this was a significant difference, regardless how you cut it and how you look at it, whether it's per one-to-one hours per month, one-to-one hours per 1,000 patient days, or when it's converted into monthly FTEs. And this is the part that was, seeing the numbers was, the total hours was one thing, but then seeing it broken down to FTEs was astounding to us. We saw that during the reference period, for that 28,560 total hours, or the 1,428 per month, this equates to roughly 8.2 FTEs for the entire period. This is compared to the 0.8 FTEs during the telesitting period. And this during the telesitting period, this 0.8, this doesn't include the 4.2 FTEs that would be devoted to the telesitter technicians. So even if we include that, there's still a difference of 3.2, which I don't have it on this slide, but it is still a statistically significant difference. And it's just astounding to see that one-to-one sitter hours were reduced tenfold or by 90% during this time. And as promised, here's the visualization of the telesitting effect on one-to-one sitter usage. So again, on the left side, we have the reference period. On the right side, we have the telesitting period. And on the right side, you'll see that there's little asterisks. Those are instances where we had no one-to-one hours reported. So there were periods in months during the telesitting period where one-to-one hours were non-essential. We didn't have to reassign, didn't have to take anyone off the floors. And it was just an incredible thing to see. We ran it and double-checked all of our records just to make sure that we weren't missing something or that something wasn't recorded appropriately, but it all, even after validating it, it still bared out. So in conclusion, before we have a few minutes for questions. I just want to say, in conclusion, we found that a telesitting program in the LTAC setting can reduce the number of inpatient falls when implemented in our way that we described today. And it can also reduce the number of one-to-one sitter hours, resulting in cost savings. Because while I didn't get to the specific dollar amounts today, with a reduction at least 3 FTEs, you can imagine how that stretched over an extended period of time, over years, will save and result in cost savings. And so some of the studies that we're looking forward to in the future are looking at to investigate the impact of two-way virtual monitoring systems. It's our understanding that Avasure has now two-way audio, two-way video systems that we're going to be interested in looking at, as well as then evaluating the impact on telesitting program on clinical benefits to see if in certain populations, if by having that virtual continuous visual monitoring, if that can somehow relay back to clinical benefits and rehabilitation outcomes. But then also we want to assess if the telesitting program benefits a specific diagnosis or program more so over another. So these are all things that we have in the works right now, but so we're very excited to look at it going forward. And before wrapping up for questions, just want to make a few acknowledgements. On our nursing team, just would like to thank Lisa Kalafis, our CNO, who in a lot of ways was the brain behind starting this project, getting Avasure and telesitting into our setting. Jennifer Lombardi, who is our telesitter coordinator, and then June Napolitano and Nicole Morrill, who are both nurse managers who've been closely working with us on this study and the implementation of the program. All of our telesitters past and present, and all of our IT stakeholders who have been helping to keep the cameras up and running this entire time. Our representatives from quality and safety who helped run reports and helped with data gathering, and then the research department, who's really just me, but just wanted to share my contact information with you all there. So, and I also have it here, so we'll be happy to open it up for questions in the last 8 or so minutes that we have today. So thank you.
Yay, Dr. Hank, that was compelling data. Thank you so much for sharing it with us. We do have a few questions for you. One question is, well, actually, before I ask the question, one clarifying point. So your data showed that you really were able to reduce your one-to-one sitters by 90%. That's accurate?
Yeah, that is accurate.
Oh my gosh. So and I don't know if you know the answer to this. So just for folks to think about this, what did you do with that sitter reduction? Did you reallocate them to the floors? Like, what did you do with those extra folks that you had on staff?
So that would so that's a great question. To my understanding, and again, I'm a researcher, not necessarily on the nursing staff, but my understanding is that those staff members that would normally have been reassigned were reassigned to the floor and kept in high need areas, especially during points where our general staffing shortages were so offset. Our staffing shortages had our matrix kind of thrown out of whack at times.
Okay. So one of the questions we did get in is, how did they enlist your help? How did Gaylord enlist the help of you in the research department to do this research? Was it I'll let you explain. I'm not even going to speak for you. You can go ahead and tell us.
Absolutely. So with the research study, it was Lisa Kalafis coming to the research department, and both myself and Pete Grivelding, who are in the Milne Institute for Healthcare Innovation. And so that's the Milne Institute's where Gaylord's research department lives. So she had the idea that this could be a potential research study. We had been for some time, prior to her coming to us, we had been for quite some time trying to invigorate research and try to get nursing staff in all of our departments involved in research. So I think it was laying that groundwork at it from the research department's end to try to make research the norm, was then made Lisa comfortable in coming to us with a project idea.
Perfect. And then my last question is, how do you share these outcomes and this research and data with your direct caregivers? Is there dashboards? Like, how do you get to share this amazing data that you've collected over the 20 months?
Absolutely. So we've been sharing it. So we've shared it directly at various different department meetings to highlight the data. We also have quarterly updates with all of our telesitters, at least those who aren't actively on the cameras at the time, where we share and highlight the most recent data. So we're regularly bringing this back to our telesitters, other key stakeholders, just to make sure that everyone's staying engaged.
Great. And lastly, and I don't know if you're the right guy for this question, but maybe we can get the answer later. We often hear when we're talking to LTACs or SNFs that financially sometimes they don't have the capacity to do something like this, a program like that. Has any of the financial implications come up, or had that been a discussion prior to going live about what kind of financial constraints or challenges you were up against?
So you were quite right. That is not I'm not the right person to be asking that question to. But that is something that we can relate back. And if anyone is interested, if they'd be happy, they're welcome to reach out. And we can try to work through those information or those questions as well. So we'd be happy to help guide and support anyone else on their journey through this too.
Perfect. Well, Dr. Hank, thank you. And I really appreciate the color coordination. The green tie looks really good. The stripes are both going the same way. So you were camera ready from the start. So we appreciate you and all the hard work you're doing, and keep it up. And we can't wait for you to publish this so that we can share it and you can share it with all of the other LTACs in the country. So thank you, thank you, thank you. I applaud you. And with that, we are going to be taking a short break. So go and refresh your coffee, grab another soda. Grab another snack if you'd like it. We have lots of snacks here, so that's what I've been doing, snacking. But we are going to reconvene at 2:15 Eastern. Obviously, I don't have to do all of the different time zones for you. Wherever you live, quarter after the hour, that's when you're going to come back, because we do have a couple more sessions, which I think you're going to be really happy to hear about. So we will see you back here sharp at 2:15. Thanks.